This week on the BackTable podcast.
And then in terms of our flaccid facial palsy patients, you have the two different categories of static reanimation and dynamic reanimation. So the latter part of this episode is talking about the static procedures, going zone by zone and figuring out, what you can achieve and accomplish. Paying a lot of respect to protection of the eye is very important, and just trying to restore function as well as form is really important for them as well.
Hey everybody, welcome to the BackTable ENT podcast. My name is Ashley Agan. I will be your host today. And today on the show, we have Shiayin Yang, who is an associate professor in the Department of Otolaryngology, Head and Neck Surgery at Vanderbilt. You may recognize her from episode 151 when we talked about synkinesis. And she's back today for a deep dive into the surgical management of patients with facial paralysis. Welcome back to the show, Shi.
Thanks, Ashley, for having me. It's good to be back.
And so last time we talked about synkinesis specifically. For listeners who haven't heard that episode, I highly recommend going back and checking it out because it really sets the stage nicely. Today, we're going to elaborate on that and get into the nitty-gritty about the surgical management of patients with facial paralysis, including those with synkinesis. Before we get into it, it's been a while since our last conversation. Shi, any updates for our listeners? I noticed you've been promoted to associate professor, so congratulations. I think last time when we recorded, you were assistant. Correct me if I'm wrong.
That's correct. Thank you very much.
What's new with you?
Not much. I mean, the promotion was huge. Really excited about that. And just continuing to kind of spread the news about synkinesis. Have been pretty busy in practice, especially with my facial paralysis patients. So got a lot of good feedback about the last episode. I think there's a ton of topics to cover, so I'm excited about this episode today.
Do you still have your like synkinesis clinic there? I think last time you had talked about you guys have, like a dedicated clinic for these patients where, that's kind of all you're focused on that day or that week.
Yeah, so it's actually this week.
Okay,
so
great.
Kind of perfect timing. We have it every 3 months, so it falls May, August, November, and February.
All right. Well, let's get into it. So starting out, I think, maybe for listeners who haven't heard our previous episode, just kind of generally setting the stage, talking about facial paralysis and, how you think about it, different types, how you categorize that in your mind.
Yeah. So I think this is a really important point to touch on. And kind of whenever I'm giving a talk or a lecture, it's usually what the first thing I talk about or touch on is just understanding exactly what is facial paralysis and in what category does your patient or, whoever's presenting fall into. So anytime you have facial nerve injury, there's kind of two different routes you can go down. One is where you have no recovery, meaning whatever side the facial nerve was injured, the face doesn't move. So complete paralysis or flaccid facial palsy, it's kind of that classic picture I think that many of us see in terms of one side of the face drooping, no movement, while the other side is able to move. So that is after facial nerve injury, you have no recovery of facial movement. And then the next category is some type of facial nerve injury and where you get partial or even complete recovery. So in the partial recovery and even the complete recovery, you can develop synkinesis. And then we kind of categorize these patients into non-flaccid facial palsy. So flaccid facial palsy is when the face doesn't work. And then non-flaccid facial palsy is when you've had some type of facial nerve injury. This could be Bell's palsy after surgery, traumatic injuries such as temporal bone fracture or excision, let's say excision of the facial nerve after a parotid cancer that has then been reconstructed with the nerve graft. And so after any type of that, if you get some type of partial or even complete recovery, you can still go on to develop abnormal facial movement, which we commonly characterize as synkinesis. Synkinesis is just a constellation of non-flaccid facial palsy. It's more non-flaccid facial palsy is a multitude of characteristics. So one being synkinesis, where you have involuntary movement of the face with voluntary movement. You can also have areas that are weak and don't move. And then you can have areas that are very contracted. So this kind of hypertonicity. So important, I think, to understand, because I think a lot of people misunderstand that synkinesis, it could only happen after maybe like Bell's palsy, but it can happen after any type of facial nerve injury. And it can even happen after you've had a successful facial reanimation surgery.
And I remember last time you talked about how it can happen, like, I think you said 6 to 18 months, like the time frame after injury can be a really long time. And so, it can be a while before patients have synkinesis.
Yeah, exactly. So you can start just as the nerve is regenerating. You may see, let's say someone had Bell's palsy and they come in 4 months after that injury and the face is completely working. They can still develop abnormal movements of the face depending on the severity of what their paralysis is, but they can start developing injury after that time frame. So I think that's why it's important for these patients to understand that, not just because you've recovered function of your face. A lot of people will say that, I've seen my primary care doctor or neurologist or whoever initially diagnosed them, and they're like, my face regained function, but even though it's not normal, there's still things that can be done, and just understanding that it can still develop over a time frame after when you originally had the injury.
In that, even if you have full recovery of your facial movement, if you're having synkinesis, unwanted movement of your face when you go to smile or blink or other things, that's not, a cosmetic issue, or that seeking help for that is not vanity, that it's a problem that there are solutions for.
Yeah, I mean, I'm glad you brought up that point again, because that is really just something that I try to emphasize with patients, because so many of them say, I just thought this was vanity and that there wasn't any reason I should get this fixed. But there's so many, functional aspects that can cause them trouble in the long term. So I think understanding that, recognizing it can really help people.
Kind of thinking about first, like managing synkinesis. So that would be, that patient population has got some full or partial recovery. And in our last episode, we talked about using Botox. We did talk a little bit about surgical management back in the last episode, but I think also before we get into that, just talking about a little bit of your process with Botox. Specifically last time you mentioned it's a process, it's a long process. You counsel your patients that it's a journey, finding, the right amount and the right muscles to treat. Kind of, can you touch on that before we move to surgery?
Kind of once I see a patient and I see that they have this abnormal movement, some people are not bothered. And if you're not bothered, you don't have to have treatment. There's obviously different severities in terms of the synkinesis. And examples, for maybe listeners who are not as aware, what I mean by synkinesis is when a patient tries to, let's say, close their eye, the corner of their mouth may move, or when they talk, their eye closes. But it can also be more than that. A lot of people complain of just constant tightness and pain and pressure. And at the end of the day, it can be really hard for them, just they'll get headaches or they just have constant soreness because those muscles are just hypercontracted. So understanding that there's a severity of disease, I think in anything we do, there's a severity of treatments. And if they're not that bothered by it, then, you don't have to have treatment. You don't need to seek treatment. This is really for those patients that have kind of debilitating disease that's affecting their quality of life. And you're really seeing some of those patients, So initially when I see them, it's a consultation. If the diagnosis was Bell's palsy, it's really determining, does the story fit with Bell's palsy? Because I have seen patients come in to say they were diagnosed with Bell's palsy that I uncover other causes. Bell's palsy, just as a reiteration, is a diagnosis of exclusion, meaning you've ruled out everything else. And because you don't have another cause, that's what it is. And it really is a clinical diagnosis. So understanding the different kind of symptoms they present with and symptoms that they lack will really lead you towards that diagnosis. So once I kind of clarify what I think is their diagnosis, it's a good physical exam, seeing kind of what parts of the face look like they're working abnormally or normally, and then also determining, what areas are affecting them. So what is it that bothers them? I may see certain things that they don't notice. And it's really understanding what kind of their motivation is for treatment. And this is kind of a resounding theme in facial paralysis, really understanding, what is that patient's goal for therapy? Because sometimes, maybe it's the smile that really bothers them, but I notice that they're constantly closing their eye and, they just have a lot of tightness in the midface region. So it's kind of aligning our goals, seeing what we can obtain. So that's why that first visit is usually pretty long, is just confirming the diagnosis, doing a good exam, and then understanding, what are their goals for treatment. After that, I usually recommend physical therapy. Starting out, it helps with biofeedback, and there are some data to suggest that there's cortical remapping after facial nerve injury. So I think working a physical therapist is pretty low risk. And there's also been research to show that patients really buy back into their treatment after starting that. And then after that, depending just kind of what the physical therapist says, because sometimes they want to do physical therapy prior to initiation of Botox, we then go into Botox treatment. So we treat with Botox. And like I said, it's a process, just figuring out those treatment algorithms and seeing how successful it is, what kind of benefit they're getting, what they like about it.
Yeah. I would think it would be hard for patients to articulate the sensations and things that they feel, unless they're like really looking in a mirror and kind of doing the movements. I'm sure they learn more about their disease process as they're doing physical therapy and looking in the mirror and being able to see what's happening. Because if you're just kind of coming in, you're like, with the smile, I think that's obvious. I've had patients that say, oh yeah, like we took a family picture and like my smile is, off. That's always a big one. But yeah, with like generalized tightness or like, if those muscles are just moving and pulling, I could imagine that would be hard for patients to articulate or describe.
Yeah, that's why I think it is very helpful. It can really just help them determine like what part of the face is really bothering them. And like you said, a lot of people don't want to look in the mirror. They don't want to look at kind of what their face is. But I think it also helps them. That's why another thing is photo documentation is very important, because the onset of Botox is very gradual. It usually takes about 10 days to a full 2 weeks to have that full onset. And then it slowly wears off. So, if having those photos documented, and then oftentimes like my new patients, I'll see back after a month to see kind of what progress we've made. And they will feel things, but then when we review the photos together, they'll really notice, oh, wow, that really helped open my eye, or that improved in the way that my smile was upturning. So
yeah, that's what I was going to ask you, is like with your assessment, how you are documenting and following their synkinesis. Because, like with facial paralysis, you have like different scoring systems like House-Brackman, to say, okay, this is the severity of the paralysis. When you're doing your assessment, what kinds of things are you noting, with photo documentation, like what movements are you having them do? And, how do you note that?
Yeah, so that's a great question. They go through a couple different poses so we can see essentially the different movements of the face. So the first is brow elevation. You have them raise their eyebrows. The next I actually kind of do, in terms of evaluation, I have them gently blink their eyes, which, it's strange because you'll see in some patients with gentle eye closure, they're actually not able to fully close their eye. But then when they forcefully close their eye, they're able to get it fully closed. So you'll see kind of different patterns as you see more and more of these patients. But the first photo is eyebrow raising. The second one is eye closure. Then I have them do a snarl to really try and see the differences in the midface. I have them do a pucker, so you can see, the orbicularis. I have them do a gentle smile without teeth, and then a big smile with teeth. And then I have them say E, so I can see their depressors and the movement there. So I document those different photos. I also take a video as well. It's a lot. The nice thing about being at an academic institution is it goes straight into the radical chart. So you can put it in their visit note and kind of document between visits their improvement. It is helpful also if you're seeing patients back who've had paralysis and you're watching their recovery, so you can see the parts that are recovering at different rates. And then you can also just show them the progress. This photo documentation is such a huge thing in facial plastics. It's really good not only for the patient, but for yourself and your learning and education, especially for the facial paralysis patients. I think it's important to really have good photos, you can really learn off of your treatments for them, especially if you're doing Botox, and then even with surgeries, what really worked, what didn't, and then just really improving the care for that patient as well as your own practice.
And so moving into the surgical management, so first kind of thinking about surgical management of synkinesis specifically. So maybe patients who have had some success with Botox, but now they're looking to maybe not, come in every 3 months or something like that. How do you think about those patients?
Yeah, so that's a great question. There has been a lot of momentum in this field, over the past 5 years, probably a little bit more than that. Because I think if you talk to a lot of people who are treating facial paralysis, the biggest portion of our practice is this non-flaccid facial paralysis. And, when you think of the kind of exciting, cool surgeries with facial paralysis, it's more geared towards your flaccid facial paralysis patients. So the ones whose face is completely not working. But really, the bulk of your practice is non-flaccid facial paralysis, so synkinesis patients. And that's a lot. That can really take over your clinic very quickly if you're just doing Botox injections every 3-4 months. And it's a lot for the patients, We have people driving 3-4 hours every 3 months to come see us. So what can we do to make it better? Unfortunately, I hope this doesn't spoil the episode, but we don't have a perfect treatment or cure for people listening. But, we're working obviously on ways that we can decrease how much Botox they're getting. So first, before kind of jumping into those surgeries, other surgeries that you can also consider for these patients are general aesthetic, trying to get symmetry for these patients. So a lot of kind of facial plastics procedures that you do for your cosmetic patients, you can also do for these patients. So a brow lift. A lot of patients, when they've had some type of paralysis, their brow does not regain function. And so you can get this big asymmetry between the brows. So easy doing an indirect brow lift, a direct brow lift, depending on the type of patient, and just giving them more symmetry for their brows. Another area is also the upper eyelid. When you get your brow dropped, you tend to have dermatochalasis or excess upper eyelid skin that can limit your vision. So, and depending on their age, many people need a blepharoplasty anyways. So they can really benefit from having the upper eyelid skin removed. Depending how weak their eye is, there's a lot of procedures around the eye that can be done. You can place upper eyelid weight if they're not getting great closure. It kind of depends on the case and the patients. I did have one patient who's taking a while to recover, especially of the eye. So I did place an eyelid weight. Eventually, they got recovery back. And so I removed it. It's a relatively easy procedure to do. I typically do them in the office about an hour, so it's something nice to help them protect the eye. The other thing you can do is treat the lower eyelid. So whether it be lower eyelid tightening, where you're suspending the lower eyelid so it's a little bit shorter. Again, in our older patients who tend to have that lower lid laxity, this is something they probably could have even benefited with before the paralysis, and the paralysis just makes it more dramatic. Another eyelid procedure doing a lot of is what's called a tarsoconjunctival flap, where you actually take a bit of the conjunctiva and the tarsus from the upper eyelid, swing it down to the lower eyelid to hitch it up a little bit better, give yourself some more support. So those are some of the things you can think of for these patients in terms of if they're having peri-ocular issues and treating them.
So for patients who are, let's say they've gotten some asymmetry with the brow or with the eye, how long does that take to develop, after their Bell's palsy or whatever the injury was? Like, are you usually doing those procedures months down the road, years down the road?
If it's like the brow and the upper eyelid, that's usually when they're more stable, so probably like 2 years out from their original injury. A lot of these people I see significantly far out from their initial facial paralysis, but it depends. I definitely have had patients who have had an acute type injury, and I've done cable graft to repair their facial nerve. And then, it's going to take a while for that nerve to grow back. And so in the meantime, if it's an elderly patient, I've gone in and done a brow, done the eyelid weight at the same time, done the lower eyelid tightening. Because like I said, even if they develop great function back, a lot of people are still very weak in their frontalis and they don't get great movement back. And they already need a brow lift. If they're older, they already likely have brow ptosis and really elevating that brow. And I will do both sides too. I try to do everything to make them symmetric. So maybe elevating the brow on the affected side a little bit more, but also elevating it on the non-affected side. So it kind of just depends on the etiology and what I'm expecting of their recovery.
Yeah, I was going to ask that if you do both sides, because a lot of people, maybe at baseline already could have used something, and then you kind of add that paralysis on top of it, and then things are really it really like magnifies it. And so luckily, sometimes it is a little hard to get it through by insurance. Just doing peri-ocular work, they tend to be a little bit more resistant, but the photos are pretty obvious in terms of kind of the issues they're having, and addressing both sides, it proves a lot for them. And really the goal is symmetry and trying to just restore them back as much as we can. Yeah, I think that's a really good point. So when you're arguing or trying to appeal insurance type issues or denials, like what kind of quality of life issues do patients experience when it's like peri-ocular? Like, are they just having, limited visual field, or like having to like over exert, the muscles around their eye to open their eye fully, and so then they kind of fatigue there? Or what's the argument you make?
It's a couple of things. I mean, first I just show them the photos and look and say, look how drastic this is. They have one, definitely overexertion if they're constantly trying to lift their brow, but they can't lift it on that side of it, is completely paralyzed. The second thing is visual defects. If they already have a, brow ptosis, and then you add a paralysis on top of that, it significantly drops it, limits their lateral vision. Anytime they look down, it's hard for them to see. The other thing for the lower eyelid is that these patients will complain of a lot of eye tearing, because not only is their face not working, but their lacrimal system's not working appropriately either. And so they'll just be tearing a lot, and that also limits their vision. So trying to help it not pool so much in the lower eyelid by improving suspension of that lower eyelid helps as well. So kind of discussing all those three aspects in terms of, just the asymmetry, visual field deficit, improvement in the tearing of the eye, and then also protection of the eye, because you want to make sure that they're getting good closure, they're protecting their eye so they can protect the vision. I've gotten the majority through. I'm trying to think of a case I haven't. And off the top of my head, I can't specifically. There may have been one or two potentially, but most of them, you have to send photos. Some people want a peer-to-peer, but it's discussing those aspects and how it's really affecting them.
Yeah, it's way more than just a cosmetic thing, like it's just restoring function to, the eyes.
Exactly. It's so much more than just the cosmetic aspect. And that's what is so important for them to understand, and so important also for the patient too, to understand. Them understanding what they're going to achieve with surgery is so huge. And I think it helps. You never want to put someone under a procedure that's not necessary. So really understanding the pros and cons about having surgery is important.
And so other things that you're doing for non-flaccid palsy.
Yeah, so I think kind of for the static ones, that's usually the biggest, is a lot of the peri-ocular work. And then the next type of procedures are really trying to work at improving the synkinesis, or the abnormal movement. So there's two different types of surgeries that can be done. One is a myectomy, where you're essentially targeting the abnormal end organ, which is the muscle. The other is neurectomy, where you're targeting the nerve that is inappropriately or rerouted the wrong way, getting innervation to the muscle and causing abnormal movement or unwanted abnormal movement. So these are kind of the two areas. They've been around for a while, but there's been a lot more traction in terms of the neurectomies recently and the procedures that are being done. So this is kind of the newer surgery that's gained a lot more popularity and is being done a lot more, and just still trying to figure out, what is the best possible outcome. So I guess kind of starting with myectomies, what you're trying to do is you're trying to target muscles that may be in that more hyperkinesis or hypercontracted state, giving you unwanted movement. the kind of popular areas targeting is the depressor anguli oris, or the DAO most commonly, that will give patients kind of this downward pulled smile. So you'll see that a corner of the mouth is kind of pulled down. And if you treat them with Botox targeting their DAO, or you treat them, you could even do a test in the office with lidocaine, kind of numbing that area, seeing if it gives elevation of their oral commissure. And that can be a good indicator that, cutting that muscle would be beneficial and would help them give the upward movement of their smile. It's something that's easy, can be done. You can do it through the mouth in the office, and you're literally just cutting out a large swath of that muscle.
When you say large, like a centimeter?
Yeah, like a centimeter, 2 centimeters, so that the muscle is completely disconnected.
Gotcha. Okay.
So that's probably the most popular one. The other one is, or other areas that can be targeted, is the platysma. So patients who have just a lot of platysmal banding, a lot of neck tightness, that's also kind of an easy area where you can target that muscle. Sometimes the depressor, the DLI, can also be targeted depending if they're getting a lot of kind of downward pull. This one's, I think, a little harder to address than the DAO, but that can also be addressed just to help improve the appearance in their smile. And these can also be done in combination with neurectomies, so doing selective neurectomy. And with that, it's usually you're deciding on your patients in terms of your patients who have been doing really well with Botox, but maybe they have a pretty severe synkinesis. They're either have a lot of tightness or a lot of unwanted movement. You've treated them with a lot of Botox. They've gotten good results from the Botox. You can also, do little lidocaine blocks to see, in the general area. So you can target kind of their buccal branch if you do an injection mid-cheek, or kind of around where margin and mandibular branch comes. So around the kind of the facial notch, that can kind of give them evidence of what, cutting those nerves in those areas might look like and help improve with their appearance. But essentially, the selective neurectomy is it's a facelift type incision. You're exposing all the nerves within the face, and then you're actually stimulating the nerves intra-op, seeing which ones are kind of giving you unwanted movement. And it's a balance of finding ones that, maybe cause this downward pull of the lip, or significantly kind of abnormal, more the depressor type movement of the mouth and the smile, and clipping those nerves to essentially weaken that forceful effect that they have.
That sounds like a much harder surgery, like kind of tracing out all those little tiny nerves.
It's a much more involved surgery, harder surgery. I think a little harder to predict as well what exactly their outcomes will be. And a lot of these patients still need Botox, or are still going to have Botox. It's not going to restore them back to what they were before. So I think it's really having a good understanding with the patient. But, even if you can decrease the amount of Botox, just having that constant relief of the pressure and neck pain, or mid-facial pain, a lot of patients find it worth it.
Mm-hmm. What you mentioned with the myectomy, the common targets are, for patients who are having a lot of downward pull around the mouth, or, platysmal banding. With the selective neurectomy, are there common movements that works best for?
I think that is evolving in terms of what people are treating that for. The common ones for myself are tightness of the neck, downward pull of the mouth, very kind of drastic, or, my patients with more severe facial paralysis who have done really well with Botox. More and more people or I'd say some of my colleagues in the country are now treating areas around the eye. The concern is, could you potentially risk these patients not being able to close their eye really well? But there's still a lot that needs to be learned about how long is this effective? How long does it work? So Tessa Hadlock a while ago actually published on patients who she did neurectomies around the eye, and found that over time, these patients still needed increasing amount of Botox. So questioning, how well does this actually work? And so the same argument can be done for the nerves around the face, and that's why, or the rest of the face. That's why I think it just needs a little bit more time to really understand how well these patients are doing after surgery. And also understanding, what do you do with the clipped nerve ends? So I think that is an area that is further being explored. So not just cutting the nerve and clipping both ends, but also taking out a chunk of the nerve. So about a centimeter of the nerve, clipping both ends. And then some people are dunking the nerves into like the masseter muscle, giving it something else to innervate. There's been some data within plastic surgery where they actually, in other peripheral nerves, wrap the nerves in muscle. So you could take a little bit of the SEM and wrap it around the cut nerve end. So I think it's an exciting field. It still has a lot more that has to be understood and better developed before it becomes anywhere near a more regimented and predictable type surgery.
Interesting. So for now, that selective neurectomy, it's not most of your patients, I would assume. That's kind of like a select group of patients that maybe have a really severe synkinesis that, they're just wanting that next step, but also it's, not predictable and there's no guarantees. And I'm sure there's a lot of upfront counseling.
Correct. So it's, at least for my practice, it's for those patients who have very severe disease and extremely debilitating disease, and trying to maybe lessen how much Botox they're getting and give them some type of permanent relief. So it's really for my patients who have them and who are really motivated and want, saying they want to do something else. They realize that and may not be able to exactly predict how it is going to be after surgery, but that they really want to do something more than just Botox.
Mm-hmm. All right, for your outcomes for the selective neurectomy, percent-wise, like how many people have improvement, or I don't know, how do you grade it? Some improvement, a lot of improvement, zero improvement? Like how do you assess your outcomes after that?
Really, it's just if we can decrease the amount of Botox and if they subjectively have improvement, because a lot of this disease, outside from the way that I evaluate them, is also, like we said, like kind of the feeling of things and the improvement in the tightness that they're having, or the feeling that it's more, they're telling me that they, have relief and they've noticed improvement in the way they eat, or if they've noticed in their smile. So that's kind of the way currently. But there's definitely avenues in terms of how are we going to grade it? How do we determine if it's really been successful for them?
Yeah. And they should notice it immediately, right? Once the nerve is cut, they should know. Yeah.
So honestly, right in PACU, you should be able to tell the difference.
That's a lot more fun than Botox when you have to wait a little while. It's nice to have that instant, like, okay, did it work? Okay. So wrapping up kind of surgical management of synkinesis. Anything else before we kind of move on to talk about static procedures for flaccid paralysis?
I think that's it, unless you have other questions about it.
Okay, well, let's move on so we make sure we kind of get everything covered in this category, because this is a different group of patients. Now we're talking about the patient with flaccid facial palsy, like you said earlier, meaning no movement, and how you think through the static procedures that you can offer that patient group.
Yeah. So just to reiterate, the flaccid facial palsy patients are those with no movement. And we kind of think about the two different types of surgeries. So the first category is static procedures. You're not trying to restore dynamic movement. Static procedures are to restore the symmetry and try to balance the face, but it's not going to give any type of movement back. So, and then the second category is dynamic. And dynamic is when we're trying to get movement of the face and have them have some type of movement back. So that's kind of the two categories when you're looking at your flaccid facial palsy patient and discussing, what can we do for the face? What are the different things in our toolbox to help improve this paralysis. And it's also important because you really need to understand what their motivations are and what you think will be the best treatment depending on what their prognosis is, the etiology of their facial paralysis, and also their underlying medical comorbidities. So in patients maybe who have a bad head and neck cancer and you have to go through a lot of treatment, they may not be ready or able to undergo a big dynamic surgery. And doing something smaller that will still, because static procedures can still give you improvement. They can help the way you eat, the way you speak, aside from just your appearance. And so I think looking at the patient as a whole, understanding kind of what their motivations are, what they want to achieve with treatment will help guide you one pathway versus another. That being said, you can also combine static with dynamic.
It's a menu and everybody's different, right? So I'm sure there's a lot of shared decision making. So focusing just on static procedures, how do you think about like the different parts of the face, and how are you counseling patients, as you just kind of walk through the different options you have that are, specifically static procedures?
You can kind of go from the top down. So we talked about this a little with Synkinesis, but we can delve into it a little bit further, kind of with our flaccid palsy. Starting with the brow, they're going to have no movement of the brow. So elevating the brow, whether we elevate one side or both sides, there's multiple different ways you can approach the brow. If you think from like a cosmetic type standpoint, a lot of people are doing endoscopic brow lifts. Usually in these patients, I don't go down that path because it doesn't give the elevation I usually need with that asymmetry unilateral. Usually what I do, it will depend on how much hair they have and their brow. But with my patients who have flaccid facial palsy, if it's a male and he's bald, usually I'll do a direct brow lift. So just right above the eyelid, I'll do both sides if they have brow ptosis and take out a little bit more skin on the flaccid side. If it's a female, they have a significant asymmetry. So a lot of times I'll do a pretracheal brow lift. So that's an incision right in front of the hairline. You're able to elevate the brow. You can elevate it on both sides. You can do a unilateral one. You're excising skin and you can get pretty good control of their brow and where you're setting it. So really just kind of addressing that brow, I would say is usually where I start first.
Yeah. And like we talked about earlier, that can add the benefits of addressing the functional part of having brow ptosis. If their main issue is, that they're having visual field defect or droop of that brow is kind of causing some issues, then that affects that as well. So you're addressing the visual symmetry part of it, but also like the functional part of the eye.
Correct.
Talking about like the moving down to just like the eye, procedures around the eye for static.
Yeah. So this is where it gets hard, truthfully. And this is an area of my practice that I actually really struggle in. When I was in training, I used to always think, oh, an eyelid weight, that's so easy. And you put it in and that's easy. But now it's really looking at more than just the upper eyelid. You have to look at the lower eyelid. You also have to look at the brow. So there's different patients where I won't elevate the brow because the brow is actually helping them close their eye. But there's some patients where the brow is so depressed that they need some type of elevation. So you may be doing a little bit more conservative of a brow lift, but also putting an eyelid weight in so that they can close their eye. Because it's kind of counterintuitive. Why would you raise their brow if they can't close their eye? But there's definitely some patients where I do both. And it just depends on the scenario, the anatomy of the patient. Because when the brow is depressed in some patients, if you have all that excess eyelid skin, they're not able to close their eyelid because it's actually interfering with the eyelid weight. So this is something I talk to them a lot about. Essentially with the eye, I'm trying to balance two opposing factors. I'm trying to get them to close their eye, but not close their eye too much. So how do you get a perfect result with that? I'm still learning. So with that, you have the upper eyelid that you're trying to close, but it's not just the upper eyelid. You also have the lower eyelid. So when you have paralysis of your lower eyelid, the lid is going to droop down. So you can get it to close pretty well, but if the lower eyelid is down, it's not going to be able to close completely. So you have to address that lower eyelid. So it's kind of concerning all these aspects and figuring out what is best for that patient. So in terms of the upper eyelid, my honestly go-to is a platinum upper eyelid weight. I will size the patient. I do like doing these in clinic because you'll be able to see how well is it working. They're usually in a procedure chair. You can sit them up easily. They can give you feedback in terms of how well is it sitting, how well is it not. That's usually what I go to first. I guess I should back up first and talk about some other options before just jumping straight to an eyelid weight. So if you're expecting the patient to have recovery back, pretty quickly, you don't have to do an eyelid weight. If they're not closing their eye, you just want to make sure you are absolutely protecting it. So one way to do that easy at bedside, you could always do a tarsorrhaphy, where you're essentially closing the lateral aspect of the eye. Patients do not like this because it can be very deforming. It can also significantly limit how much they're able to see, but it's something that's easy and in the right patient can be appropriate. So that's just kind of the first step. Tarsorrhaphy can be an easy procedure, done at bedside. Closing the lateral part of the eye can be easily undone. Another option is if you expect them to recover quickly, a scleral contact can be really nice, contact lens. It's a little bit harder to manipulate, but putting that into the eye can hydrate, protect the eye. Lots of eye drops, I have them, even if I'm doing an upper eyelid weight, drops throughout the day, ointment at night, because I find the ointment is the most lubricating, but it can cause you to have blurry vision. Another option is moisture chamber. It looks like an eye patch, but it's usually clear so you can see through it. So these are all just ways to hydrate, keep the eye intact, protect the eye. If you're ever unsure, just refer, often I always have them see an ophthalmologist, look at the eye, make sure it's okay. Because that is just very easy to, you don't want to damage it and you don't want patients to have inadvertent injury to the eye.
Yeah, they're already dealing with their facial paralysis. So you don't want to add another issue on top of everything. When you are doing your assessment, can you support the brow? Just when you're clinically looking at them to be like, okay, if I pull it up this much, is that going to, make them to where their eyes, where we're pulling their eyes open? Does that help you at all? Being able to just kind of.
That's exactly what I do. So I do support the eyebrow at a position that I want it to be at. And then I will see, how much is it closing? How much excess upper eyelid skin do they have that's interfering with their closure? Because some people don't need anything because their brow is so heavy and they're able to close. So if that's the case, and I expect them to regain recovery and they're doing okay, then we'll kind of go down that path and just make sure they're doing drops and ointment. That's usually never the case, but that is an option if they're protecting it. They can also tape at night. So you put a little strip of tape at the bottom part of the eye, and then I usually have them do at the lateral aspect of the eye to try and tape it closed. You don't want to strip directly over the eye. I prefer to not do the taping because I worry that they won't necessarily do it right. I think it's easier just to wear a moisture chamber. So evaluating them though, no, I do raise their brow. And then we have weights that you can tape on to the eyelid. And that's how I measure to determine what weight they may need. If they don't want to wait, you could also do a temporary external eyelid weight where they just tape it onto their eyelid. It doesn't have to be a procedure. But I've had plenty of ones that I have revised where I've either placed it's too heavy, it's too light, it's not in the correct position in terms of where it's at. So I usually try to place my eyelid weight more medial, so somewhere between the medial limbus and mid-pupillary line, and balancing how does this allow you to close your eye, but you're not closing your eye all the time. And then when you're thinking about the lower eyelid, this is where it can get significantly more difficult because you're looking at not only the eye, you've lost movement, you've also lost tone. So as we age, our midface ages, it's already pulling down on your lower eyelid, then you've lost that muscle tone. So if you're older, it's really going to pull down. And then if you have excess eyelid skin, that's going to complicate that even more. So that just makes it even more challenging to address. So kind of the different steps you can think of. If they don't have that much laxity and they don't have that much lower eyelid ectropion, you can do a lateral tarsal strip where you're tightening that lower eyelid up and bringing it to a more appropriate position. so that when they close with the upper eyelid weight in, they're able to close. If that's not enough, another common procedure I do is the tarsoconjunctival flap, where I'm taking conjunctiva and tarsus from the upper eyelid, bringing it down to the lower eyelid. It's kind of like a suspender, so suspending it up. It's not as deforming as the tarsography. You do see a little bit of the flap in that lateral aspect of the eyelid, but I've found it to be very helpful just in hitching up the lower eyelid. In really severe cases, sometimes you have to restore that lower eyelid portion and put some type of spacer graft for your middle lamella. So a cartilage, auricular cartilage graft. These are for your patients that, just have significant laxity, a lot of excess eyelid skin. And I mean, their midface is already drooped because of their paralysis, but even before that, they probably had midfacial droop. And then there's those patients, if they have a lot of laxity medially, those are usually the ones I'll refer to my oculoplastics colleagues to manage.
Yeah. So a lot of different options, a lot to think about when it comes to static procedures of the upper face and around the eye, with the main goals being around eye care and kind of maximizing the patient's visual field while also giving them the ability to close their eyes and make sure they're protecting their eyes. Moving on to kind of other procedures, kind of maybe in the mid and lower face, what else is in your toolbox?
So the next one is static sling. This is where I'll take tensor fascia lata from the thigh. You do a facelift incision, elevate a facial flap in your subcutaneous plane, taking that tensor fascia lata, and then I'll cut a couple different strips, because what I'm really trying to target is, depending on their symptoms, but a lot of patients will have nasal valve collapse. So I'll do a couple different strips. I'll do a strip from the nose up to around the zygoma. Usually I do a broader strip where I'll try and catch some of the upper lip, the oral commissure as well onto the lower lip, and then bring that, whether it be one strip or two strips or a large strip, bringing that up. And depending on the patient, they can have significant laxity and pull to the unaffected side. So really trying to bring them more to kind of in a resting position, opening up that nasal airway and improving it so they're not constantly biting on their cheek, biting on their lower lip. And it also will help them speak better. That is something that I do in a lot of my patients who are older, who maybe have more medical comorbidities, do not want a bigger dynamic procedure. It's a good option. It can really give them significant improvement in breathing, speaking, and eating. And so I've had patients where it's become loose, and I've been able to resuspend that in clinic. And right away, they're able to know like, oh, I can breathe, or the mouth feels in a better position. It's kind of I'd say unsexy side of facial paralysis, but it's effective, and it makes a big difference for these patients. It also can be done at the same time you're doing a dynamic procedure. So I've done this in patients where I'm cable grafting their facial nerve. So if it's a cancer excision, it's an older patient, I do a cable graft and maybe a masseteric to facial nerve reanimation. You can, if they have a lot of laxity and I know it's going to help, then I will also do a static sling at the same time, because that will give them improved resting symmetry while I'm waiting for that nerve to grow back. I would say, aside from the patient who doesn't want to have a dynamic surgery, the static sling is a good procedure for those patients, but it's also good in conjunction in the right patient for select dynamic procedures.
Mm-hmm. Yeah, because you're going to have that instant result, and then so it gives you some symmetry while you're waiting for your cable graft to work.
It can give you symmetry. It can give you, improved function. There is, talk about how far do you pull it? How much do you pull it? I tend to try to not drastically over exaggerate the pull of the tensor fascia lata. There's concern of how much is it going to stretch or loosen. I've found kind of a little bit more tighter than what I would want it to be, but not drastically overly tight. I've found to be kind of a good in between. But another procedure that I've found to be hard. And another modification is actually doing it in a similar way as to deep plane facelift. So going sub-SMAS and you get a little bit more bulk from the tissue, a little bit more that you can anchor it to, and then giving them kind of that increased support.
And you have pretty good longevity with that?
I do with the tensor fasciae lata. I've definitely had patients where it has relaxed in figuring out what to do. So recently I had a patient where that happened. They weren't really excited about having to go under again for a surgery. So I was able to open the incision in clinic. I kind of opened the superior aspect of the incision, found it was still, connected and then attached. And then I just resuspended it, tightened it more, resuspended it. So my thought is that kind of the graft relaxed over time. And so hopefully they do well and it doesn't happen again. But, it's kind of one of those things that's a risk of that procedure.
Yeah. I mean, all of our tissues are stretching and, like loosening over time, including the graft that you put there. Other procedures for helping create symmetry in the lower face.
Yeah, the only other one I would say, this one I don't really do as much, but I've had it in one or two patients where actually the lower lip has just been very stretched. So in some patients, and I've done this in a lot of post-cancer reconstruction patients as well, actually taking a little bit of a wedge of the lower lip can help shorten it so that they have improved oral competence. So in those patients who have maybe like an extremely stretched lower lip and they're just really pulled to one side, they're drooling a lot, they're having trouble with oral competence, I have done it in a handful of patients, both facial paralysis as well as post-cancer reconstruction. I've found it to be something that's relatively easy to do to improve overall oral competence, eating and speaking.
Yeah, which is huge for the patient, to be like eating and speaking. It's what we do all day long. So yeah, it's a big quality of life factor.
It is. The other thing, just kind of around the mouth too, is some things you can consider as well as fat grafting, because you have to think of these patients, not just that the face isn't working in facial paralysis, but you have to also think about just their general aging. So some people also benefit from fat grafting, and just giving them more volume will help to improve oral competence, helping them close, helping them eat and speak. And yeah, it helps their appearance. And, I think the more harmony and the more symmetry you can give back to these patients, the better it helps with their overall mental health, which I don't think we talked about it much today, but last episode, I mean, that's just such a huge part of this and such a debilitating part of this disease. The more that you can kind of restore them, the better it is, the better result you get. So I really think looking at these patients, not just what muscles are not working and, how is the face not working, but also understanding from an overall harmony and symmetry standpoint, trying to restore that and restore both sides. So really, like I said, is like with the peri-ocular work, addressing both sides, addressing the eyes, that can have a huge impact for them.
Any other surgeries that you want to mention for this patient group?
Yeah, so I think there are a couple or two other surgeries that come to mind that I think we should touch on. Typically, these surgeries are dynamic surgeries that we usually treat flaccid facial palsy patients for, but there's been some research, some of my colleagues across the country have done them. The first is looking in to see if any type of neural reanimation, so masseteric to facial nerve reanimation, could that help with in conjunction with a selective neurectomy. There's been some studies on it, but I don't think the data has been great. So I don't think this is an area that potentially will continue to gain momentum. But the thought behind it is, can you cut some of the facial nerve and interrupt that synkinesis and give it input from somewhere else? So masseteric to facial nerve reanimation is when you connect the nerve to the masseter to a branch of the facial nerve. And in patients with flaccid facial paralysis, it can give you really good oral commissure excursion, because the masseteric has a significant amount of axon and is a very powerful nerve graft. And so the thought being, in these patients who have synkinesis, who are not getting oral commissure excursion, could we input the masseteric nerve into the facial nerve and get that excursion? And I know that there's been some research, a select handful of patients where this has been tried. But I think over the long term, the unfortunate result is that the synkinesis tends to overpower even the mesenteric effect. So I think, unfortunately, that's hasn't kind of bore out as a really great option. But I think it is, an interesting school of thought, an interesting, avenue that has been looked at. The second surgery that I personally have not done yet for a patient, but I know other people around the country are doing a gracilis, so free muscle transfer to improve commissure excursion, improve patients' smile who have severe synkinesis. So you'll have some patients who are getting no oral commissure excursion, and essentially you're taking tissue from their thigh, putting it into the face to recreate a new movement and help improve their smile. So I think once we have a little bit more data on this and the improvement that patients could potentially get, I think this could, as well as the selective neurectomy, be an additional avenue that our synkinesis patients might have.
Interesting. So those patients do not have flaccid facial paralysis on that side, but they're not able to have that smile. They're not able to elevate the oral commissure. And so you're specifically kind of trying to fix that problem.
Exactly. So it's, you can have some patients who are so severe, it looks like they're just frozen. And I have a patient, she has bilateral facial paralysis and she just looks frozen. She can't move her mouth. She can't close her lips. So I think if, in the thought is in the right patient, you're essentially just creating a new muscle to give them smile. And, granted, a gracilis, traditionally we think of that being used in our flaccid facial paralysis patients who are out too long to do a neural reanimation. Those are typically the patients who are receiving these types of surgeries. But can we apply this to our synkinesis patients? Some people already are. And I think seeing more data, more outcomes of these patients and really determining what are the best treatments, that's the frontier of this. Yeah, I mean, the best treatment is improving regeneration of the nerve. But until then, kind of these are the procedures we have to treat these patients.
So this has been a really awesome and thoughtful and full discussion. Thank you so much for taking the time. Anything you want to leave our listeners with?
Yeah, so I think just a couple key takeaways is one, for synkinesis, aside from Botox and physical therapy, in the right patient, there are options for surgery. And, first is trying to restore symmetry to their face. So whether it be peri-ocular work, a brow lift, or blepharoplasty, these can have significant improvement just on the overall quality of life. But then if you're trying to go more down the road of targeting that abnormal facial movement, some patients may be a great benefit for myectomy, which is something that could be done in clinic. And then for your patients who have had a lot of improvement with Botox, are really motivated to do something more, considering talking about selective neurectomy is a good option for these patients. And then in terms of our flaccid facial palsy patients, you have the two different categories of static reanimation and dynamic reanimation. So the latter part of this episode was talking about the static procedures, going zone by zone and figuring out, what you can achieve and accomplish. Paying a lot of respect to protection of the eye is very important. And just trying to restore function as well as form is really important for them as well.
Yeah. And you're going to come back and you're going to be talking to Dr. Loya Lee about the dynamic procedures. So we had a little teaser for you guys. Stay tuned. Coming soon. You guys are kind of going to do a part 2 of this to be able to dive into the dynamic procedures, which I think will be really amazing as well. So thank you. If people want to find you, you're at Vanderbilt, you're on socials. Remind me your Insta handle.
It's Shiayin Yang MD. So SHIYANG MD on Instagram.
That's a wrap.
Cool. Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.